To SBI Summer Series. This is a weekly summer webinar series that is developed and organized by the Social Media Committee of the Society of Breast Imaging. Like I said, this is year 3. We are happy to have everyone back and everyone to watch us and join us on these informal discussions about all things breast health. I will first, I want to introduce the panel. I'll have the panelists introduce themselves, and then I'll kind of get into a little bit more of the introduction of the summer series in and of itself. And then we'll get into today's topic, which is breast imaging and the ongoing COVID pandemic. So we'll just kind of go around the panel here. We'll start with Toma.
Hi, everyone. My name is Toma Omofoye. I'm a breast radiologist at MD Anderson Cancer Center in Houston, Texas. Thank you for having me. Glad to have you all join us for this discussion today.
Awesome. Thanks for joining, Toma. Next, we'll go to Jill. Oh, Jill.
I forgot to unmute myself.
You're good. You're good.
I'm Jill Zhang. I just started as an assistant professor at Jefferson Health, Einstein Healthcare Network. So very excited to be here. Welcome,
Jill. Glad to have you. Jill is a veteran. I think Jill and Amy have been on this since the beginning. And Elisa, you're next.
Hi, everyone. I'm Elisa Sumkin. I'm a breast imager from Allegheny Health Network. This is in Pittsburgh, Pennsylvania. Thanks for having me.
Absolutely. Welcome, Elisa. Right down the road from me, colleagues at Allegheny Health Network. And we will go last, but certainly not least, Amy Patel.
Hi, my name's Amy Patel. I'm a breast imager in the Kansas City area. I'm a medical director of the Breast Care Center at Liberty Hospital, which is in the North Kansas City area. I also oversee breast imaging for 6 critical access care hospitals in Northwest Missouri and an underserved health center in urban Kansas City. And I'm also an assistant professor of radiology at the University of Missouri Kansas City School of Medicine. So really grateful to be here this evening.
Awesome. Well, we're happy to have all of you as panelists. My name is Matt Miller. I am a breast imaging radiologist, also at Allegheny Health Network in Pittsburgh, Pennsylvania. I will be starting my 4th year as a staff at Allegheny Health Network, along with Dr. Sumkin, and I'll be moderating this panel. This summer series, I kind of alluded to at the beginning, is in its 3rd year of development and implementation. Which was initially started by the Social Media Committee as a response to the COVID pandemic. We were trying to just figure out ways to get education out there while people were kind of at home quarantining and whatnot. We came up with this webinar project that kind of snowballed from there and became a great thing. It is a national and internationally viewed webinar series. So we welcome all of our viewers from local and abroad. These are recorded and will be available on all of the Society of Breast Imaging social media platforms. So if you are watching on YouTube or Twitter or Facebook and you have to step away, fear not, you can log back in at a later date and catch the rest of these discussions. So the first couple of years, we tried to organize the discussions to be kind of in a sequential process and kind of taking our audience into account and organizing it in a stepwise fashion, going from education for radiologists to clinicians to patients and family members. This year, we kind of looked at what we've done in the past and we opened it up to you, the viewers, to provide us with some feedback. And we took some of the topics that we were recommended to discuss, and we will be hosting webinar series throughout the summer based on some of those topics. So if you are interested in seeing what the topics are, what the schedule is, they will be every Wednesday from now until the middle of August at 7 p.m. Eastern time. And the schedule is up on most of the Society of Breast Imaging's social media platforms and a lot of our personal social media platforms. I know it's pinned to my Twitter profile. So if you'd like to see what the schedule is, it would be on there. I'm just Matt J. Miller, MD, on Twitter. So the schedule is available there. So if you're new to this summer series and you don't really know what this is, you're just clicking on a link because it says so on the Society of Breast Imaging website. Welcome. These are informal discussions. So obviously you see that we have 4 great panelists here that we will be discussing the topic at hand. Different weeks will have different number of panelists, but usually we keep it around 4 to 6, sometimes a little bit more. And the topics range from, stuff that's geared towards the audience of radiologists to more kind of broad patient-centered topics and everything in between. We do some stuff about breast imaging education, radiology education as a whole, social media. So we really try to kind of hit all different audiences at a given week. So definitely pay attention to the schedule to see if the topic that will be discussed that week interests you and is something that you'd like to watch. Please follow us all on social media. You can get to us by the Society of Breast Imaging social media platforms. We all have our Twitter and Instagram handles there. We'd love to interact with you. So, this is all basically driven by interactions with people on social media. So if there's something you'd like to see, if you have suggestions or input for how we can make this better, please reach out to us. We are not difficult to find and we do not bite, I promise. So without further ado, that's kind of my plug for the Society of Breast Imaging Summer Series as a whole. Why don't we get into the topic today? So today's topic is COVID. And at this point, a couple of years into the pandemic, everyone's got quote unquote COVID fatigue, right? But it is something that is still a topic that needs to be discussed, that still impacts us as breast imagers and our patients. So we can just kind of go around the table and kind of discuss how COVID initially impacted you as a breast imager and how it continues to impact you today. So whoever wants to start.
I'll start.
Well, I can start.
Go ahead, you go.
I'm sorry. Okay, I'll
No,
start.
go ahead.
So, we happen here to take care of a pretty vulnerable population. We have a lot of patients who are immunocompromised. And so from the beginning, we've taken the pandemic really seriously. So I'll say initially, as most of the world did, we went into semi-lockdown and really tried to learn more about COVID and the disease and ways to mitigate risk and transmission for our patients. But I will say that since we've learned more about the disease, since vaccines have become available, we have kind of opened our doors really full force, certainly as safely as possible, but really intentionally have worked to provide access to patients as much as possible in the safest way possible. It's funny to me when I see on the news or in the grocery store, they talk about people being reluctant to mask and such. That's not the case in our workplace. Everyone is masked all the time. We continue to use enhanced cleaning and sanitation methods, but we've really taken a lot of effort in knowing that some patients really never caught back up after missing their mammograms in 2020. It got off of their schedule. And so we're just really sensitive to that idea. So we have expanded our hours so that there's more availability for patients to come in, including on Saturdays and some evenings, including for employees, just because we would like to make it as easy as possible for patients to come in with the assurance that we're doing everything to keep them safe while they are here for their mammogram screening or diagnostic appointments.
Absolutely. Absolutely. So that's a great point, Toma, about, keeping people safe and whatnot. I assume everyone still has, a masking, I don't want to say mandate, but a suggestion of a masking. So when I go to work, I put a mask on and I don't take it off until I go home. And all of my patients do the same. Is that everyone else's experience as well?
Yes.
Yes, but I also think that we are, encountering challenges as well. Some patients don't want to wear a mask and they don't understand why they have to wear a mask. And then, being on the leadership side of it, to be quite honest and to speak to your first question, it has been very challenging. Anybody who has been in charge of the operational aspects of this, anywhere from implementing all safety measures to, pausing screening mammography and working with C-suite leadership about when to stop and when to resume, and then now we still have to continue with our cleanliness measures and safety, and patients just so fatigued from COVID and not understanding. I think it's been challenging for the whole team. I specifically, for us, and I don't know if you all are experiencing it. I'm guessing you are. If you are a breast center that you're still having your technologists ask about last COVID administration arm, that kind of thing, unfortunately, a lot of patients snipe back, and they can be kind of challenging with our technologists who are just trying to do their job and just trying to get the information for us. So I think that, we went from this really trying to make sure everybody was safe and having all the measures in place, which we still are trying to do, but because of the fatigue factor, it's making it even more challenging, I think, for our teams, especially when we encounter certain patient situations.
No, that's a great point. That's an absolute great point. I want to stay on that topic, but I'd be remiss if I don't welcome our other panelist, Nina Vinkoff. Thank you for joining us. Excited that the technology issues are behind us. Welcome.
Two
yourself?
laptops later, and I finally found one that would let me into this podcast, into this series. So
Webinar.
Here I am. Thanks, Matt. Sorry about that.
Absolutely. Well, we're happy to have you, Nina. Thank you for joining us. She's also a veteran to the summer series, so we're really excited that she was able to get on. So absolutely, Amy, you talk about COVID fatigue, and I think we're all seeing that, not only in the workspace, but in our personal lives as well. I mean, it's definitely a real thing, and it's kind of a timely thing with the FDA just coming from a person with young kids. They just released the COVID vaccine is now available to 6-month-olds and greater. And, a year ago, it was like, everyone that I knew probably would have rushed to get it. And now I got people texting me being like, do I really have to get my kids the vaccine? Do I really have to? Yeah, it's still recommended. It's still, COVID is still out there. But that fatigue is definitely a real thing in all facets of what we do, not just breast imaging. Absolutely.
And I think it's important that, it can really affect team morale. So those of you on the panel tonight, I don't know if you've also experienced this, is, for me, I think it's really imperative to continue to ensure that the morale and the well-being of our technologists is still intact, because they are truly on the front lines and they do deal with the most abuse. And so I'm always very cognizant about what our technologists are going through. And frankly, sometimes they do deal with very challenging patients and situations. So I think we need to take it upon ourselves, whether you're a section chief of breast or whether you're any part of the team, we're all integral in ensuring that our technologists are safe and that their well-being is being looked after, and that we're ensuring that they have the support that they need, because they've had, arguably a more challenging time during this entire pandemic than even us.
I agree. I really appreciate you highlighting that point. In some ways, our technologists are the front of our organization, right? They are very patient-facing. I do find that one thing that's been beneficial for us is the consistent messaging from leadership, as much as all of the leadership, not just within the breast center, but the entire organization is saying these are our policies, so that some of those screening questions are actually answered by the patient before they present to their mammogram appointment, and they get enough of our policies shared with them that they are pretty aware of what they're agreeing to when they step in the door. And furthermore, I think it helps to provide a sense of camaraderie for the technologists, and knowing that the entire organization has their back as they, try to encourage the patients to adhere to the COVID policies.
Yeah, I wonder also part of it with geographic related, because I live on the East Coast, actually haven't really encountered many issues. healthcare organizations require mask, and the patient has been pretty compliant. So so far as I know, most patients are doing what we recommend.
I think you make a great point. Geographics is so important. I mean, unfortunately, there are hospitals even in Missouri that aren't going with a mask now. Fortunately, all of the ones that I oversee are wearing masks, and we're still implementing these measures. But to your point, Toma, you might have a very rural hospital that's unable to give that communication and messaging ahead of time. There's just like certain technological limitations and that kind of thing. And so unfortunately there can be situations with certain breast centers, whether you're hospital based or outpatient, and the patient shows up and there unfortunately just wasn't communication beforehand. So I think it's very challenging depending where you live, what kind of facility it is. So I think all around it's been very, very challenging in certain aspects.
Yeah, I mean, that's reflected sort of everywhere. And even I think we'll get into this later on, but geographically, we've treated it differently. We've approached it differently. The patient population is different, and how they've been affected, and who has had less screening. It's all been different across the country depending on where you are. So, and being in Pittsburgh, basically almost East Coast, but it's every one of my patients has a mask on, and I have never had anybody thus far complain to me about it. Within these more recent times of COVID, where it's just become standard in the hospital of ours to wear a mask, and the technologists, everybody. Like we said, they're the ones that are closest to the patients too. They're the ones that really are the front lines. When they're taking mammograms, they are just inches away from their face. So they're so good at wearing their masks and, keeping the protocol. And our hospital sort of went back and forth, as I'm sure you guys did too, with depending on where we were, the different times of the pandemic, whether or not we were supposed to wear a face shield, what type of mask. They got rid of cloth masks. We're no longer allowed to wear them in the hospital. But I started wearing my glasses all the time. I never wore my glasses, and now I wear them all the time because I felt like it was just eye protection. So things have definitely evolved over the last few years. But
what about screening questions? Are you guys still screening people? And do you actually think that people are telling the truth on their screening forms? Like, I almost feel like there's no point in really asking people screening questions, because people that want to come in and be seen are going to answer the questions the way that they know they need to answer them in order to be seen. And I almost feel like we punish people who are too honest sometimes on their screening forms. If somebody says that they've had an exposure or a possible exposure, are you letting them come in? Are you not letting them come in? And how long after they've recovered from COVID are you allowing them to come in if you are setting up those kinds of barriers?
It's a great question.
So I'll tell you what we're doing while you all think about it.
Yeah.
We're letting everybody. And what the crazy thing is, we're asking them all the questions. So I hope nobody from my health system's listening to this, but I think, it's kind of crazy because we're asking them all the questions, but if they say they want to come in, even if they actively have COVID right now, we're letting them come in. And we're treating the people who tell us that they've recently had COVID or had a documented exposure. We're treating them in a different way than we're treating everybody else, right? So if they tell us that they have COVID, now we've got everybody gowned and masked, and but
you're still doing the exam.
But those are only people that are telling us the truth, or who even know. Like, I feel like everybody's getting exposed all the time, and most people, even if they're trying to be honest, don't know whether or not they've been exposed. So I think our inconsistency around the way that we handle some of these things is what leads some of our patients to become so frustrated with us. Is it just doesn't feel like the rules are clear, and it feels like they're being applied sometimes in a way that's inconsistent. And then patients get really frustrated with us.
Elisa, I don't think that we're asking people about exposures anymore.
I don't think so either.
But we are asking about vaccines, which doesn't make terribly much sense to me anymore.
No.
But because we can get into that. We talked about that ad nauseum last year, but you know, we still asking about the vaccine. I used to report it for the first couple months that the vaccine was, you know, prevalent and everyone was getting it, you know, acutely. I was actually putting it in my screening report that, you know, a patient had a vaccine 2 weeks ago or whatnot. I don't even really, the only time I pay attention to it is if I see lymph nodes, which is, you know, rare. But as far as screening exposure wise, if we are asking about it, I don't know about it because
we are asked. The only time I see it being, I know that they mark it on our MRI sheet too. I guess that's helpful too, whether or not they've had the vaccine. I honestly don't pay attention to it that much anymore. Because I feel like it's been so long ago too, and so few people are actually getting it now, getting the vaccine.
You're talking about the vaccine, right?
Yeah. That, you know, because we were looking out for it obviously for the adenopathy, and now it's like that was so remote. I mean, I don't even remember the last person that I saw that had the vaccine, you know, within the last few months. I don't know.
I think in our healthcare system across the board, before the patient come in, we still ask those questions. It would either be, you know, through the patient portal, and then if they answer yes to any of the questions, they would be suggested to contact their physician's office before they come in. And I don't know if different specialties or different people handle it differently, and then or they just ask them at the front desk. We also ask trips outside of the country within the past 14 days, but I don't think that one necessarily affects their ability to be seen. I think more about the question like, have you had a positive COVID test, or have you had recent exposure? I think those are the questions that will, apply some isolation time, quarantine time.
Yeah, same as.
And so you still have quarantine time. You're still isolating them. You're still quarantining them.
I'm actually not sure. I don't know. Because the questionnaires are across the board the same in the healthcare system, but I don't know if different subspecialties are doing it differently. But I think the CDC still recommends if you have COVID, you should, try to quarantine. So
we laugh, but no.
An active case or recent exposure, we really have to be cautious with that. Especially of recent, there's all of this data showing where I am in Houston, the wastewater is up to 500% more than it was this time last year, right? So it's not really just about that one patient and then potentially having a delay in their mammogram appointment for a couple of weeks. We have to also think about the exposures to our other patients and certainly our staff, because we have pretty robust policies also for quarantines for our staff. Again, we have a vulnerable population. And so it's just really important in general for us to keep in mind that giving that one patient that opportunity to come in on this day could have this domino effect. If all of our staff is out, then you would have to close down the center. And then now you have 100 patients whose appointments have to be rescheduled, right? So we continue to kind of weigh that. So at this point, we proceed pretty cautiously with it.
Absolutely.
Yeah, I mean, we still are doing the screening, whether or not people are, honest about it. I mean, we would hope that they'd be. We do have a, fair share of patients, and specifically when we were really at the height of COVID, that if they had any symptoms and even if they tested negative, we did have a lot of patients I would call and say, just to be on the safe side, to protect you gals, I think I'm going to reschedule. So that was really, really thoughtful of a lot of patients, and we appreciated it. We saw a lot of after the facts, hey, just calling to let you know that I was in your breast center a couple days ago and I've now tested positive for COVID. So I just wanted to let your team know. I feel like we see a lot of that more than, seeing an active, a known active case of COVID in the breast center. It's more kind of after the fact where they call and say, hey, I'm so sorry, but this is sort of the case. So then we backtrack, who is all interacting with this person. And that can be very, very challenging as well. But we still do that. And then we, of course, still ask about COVID vaccine administration. And I mean, we still are having some patients who even their second dose, they just got it recently. And again, I think that speaks to geographic variability of COVID vaccine administration as well. So we're still seeing the COVID effect of lymphadenopathy as well. So.
Absolutely. No, these are great points. I want to get into some of the scheduling. I want to get into kind of, the timeline of COVID, happened in, March into April and May a few years ago. Are your breast centers still seeing kind of those waxing and waning, slow down in April and May and bolus back up in June and July? Because we definitely are.
Mhm.
Yeah, we are as well. And I joked about this last year. I think I was joking with Nina about this last year. I think we need to have another breast cancer awareness month type push in March and April, because, and it's honestly 6 months away from October. But people are creatures of habit. Those people who were on that March, April schedule that was disrupted in 2020, some of those people just don't get back on the schedule. They just don't have their reminder letters. As far as we can tell on national data and our facility data, it does appear that we're still below the typical screening rates. So I think that, SBI, whichever of you all have power, I think this is a great initiative to do a return to care in March and April, just a push for return to screening mammography.
I have a question about how assertive all of you are in your places about getting people to come back who have missed their appointment. I think we probably all have worked into our tracking systems, whatever system that we're using, a reminder that it's time for your appointment. But do any of you actually reach out to patients by phone or by text or, electronically, apart from that letter, and try to get, a scheduler on the phone with them to say, you're overdue. Can I schedule you for your appointment now? Is that something that anybody does or would think about doing?
I don't do that personally. I can tell. Sorry if I'm sorry, but I do know that there has been an initiative here in Allegheny Health Network to get people to get the primary care doctors kind of on board on almost cold calling patients and making sure that on their annual exams, making sure that their annual checkups. You're coming back for your annual checkup. Did you have your mammogram over the last year? Okay, well, we got to get your mammogram. And so that's kind of the push. There was some re-education that went out to the primary docs. But as far as radiologists making those cold calls, we're not doing that here at AHN. But that's a great idea.
We are.
Wow, that's great. Yeah, I think
we're going to actually start just running lists of the people that missed their appointment, because I think it's one thing to get a letter in the mail, which you can just sort of toss in the pile of the rest of the mail. It's another thing if the person who contacts you actually has the ability right there and then to schedule you. And I think it's really powerful if the phone call comes from a person who says, hey, I see you missed your appointment, and if you have your calendar open right now, we can get you booked right now. And
so I think that's key. That's key to implementing. I love that. I absolutely love that. If you're going to do it, have the ability to make the schedule, because that's getting a phone call saying, hey, you need to schedule. Here's the phone number.
I want a scheduler to call and just say, we noticed that, you're overdue.
Opening next week.
Yeah, we did. We put forth this multidisciplinary approach to it, working with some of our cancer prevention docs, which we, sort of closest thing we have to primary care, and some of the they also manage some of the high risk population, and really took some time to sit through and run the lists. And not the radiologists, but the schedulers have helped us to contact those patients one-on-one. So please, Nina, let us know how this goes on your end. I think that'll be interesting to find out as well.
Yeah, I think we're all busy, and it's been a really disruptive couple of years, and somebody making it a little bit easier for you by saying, I can take that task off your list and just do that for you right now, might be the thing that pushes people to get back on track. I don't know. We're going to find out.
Yeah, that's great.
It's funny. This is kind of topical. Go ahead. I'm sorry.
No, I was just saying some of the electronic medical system can send a generic text to the patients, but they cannot schedule real time. So I think trying to call those patients is definitely a great effort.
What can do it though is these chatbot functions now. We don't have it, but I'd love to get it in our health system where a chatbot reaches out to you the same way a human does on your text, and you can click on a link that'll then connect you to the person that's going to schedule you. And
I would be afraid to click on those, that it would be some kind of spam. We're always getting these random things and random phone calls. I think I would ignore the phone call and then just miss it.
I think it definitely takes a multifaceted approach from phone calling to letters. A lot of our patients, specifically in the rural areas, they don't have a phone number. So we have to mail. So I think from digital technology to just good old fashioned mailing a letter to, we also offer walk-in mammograms. So routine screening mammograms. So if they, from 6:30 a.m. to 3 p.m., they can come in. They don't need an appointment for a routine screen. They don't need an order, and we just work them in. And so we have found that has also helped, especially with the patients who are behind on getting their mammogram. That's been helpful for us as well. And as far as, I try to always be cognizant, of our staff. And so we actually employed in an hospital wide at my main hospital, our main breast center, is an employee mammogram day. And it was it took a lot of time, about a year and a half, for me to implement, but we executed it, and it was fantastic. And we had so many staff workers that hadn't had a mammogram for years. They'd just been working and working and working. We were able to work it out so they could take time from their schedule when they were on their shifts to run down to the breast center to get their mammogram. And now we're going to have another one in August. So that has also been an effective way to take care of our own as well and make sure they get back on track.
We're inviting people now to, if they're part of any kind of social group or community, that to tell, like, we'll set up a date for them. Like we just did, actually, one of our OBGYNs is very active in her sorority. It's like a national Black sorority that she's still very active in. And she invited all of her sorority sisters. We opened for them for the day on a Saturday last week. And she just said, if you're due or overdue for your mammogram, come, you don't need an appointment. And it was great. And they came. So I'm going to start doing that more, of just basically saying to people, like, if you're part of a group of people that you can get the word out, we'll open for you, or we'll stay open late for you if you can bring people in with you. Any of you guys do mobile van?
Oh,
we're in the process of developing. Where I did my fellowship at WVU, we had a mobile van go throughout the whole state. But real quick, I wanted to kind of get back to some of the things that Amy and Nina both said about kind of ways of outreach and whatnot. One of the things that, in addition to working with the primary care people at our institution, that we identified, we were able to get a list of people who have missed their mammograms over the last couple of years, and we have their birthdays. And so we're planning on, and we have already implemented, sending out birthday cards. Happy birthday, get your mammogram, from Allegheny Health Network. And so that was one idea, that just instead of kind of sending out, bland letters or bland emails or whatnot, here's a birthday card. Oh yeah, I need to get a mammogram. So I thought that was a great idea. And we're talking about getting an additional breast cancer awareness month in addition to October. One of the holidays that kind of is a natural fit is Mother's Day. And so Mother's Day is something
brilliant.
You know what I mean? It's something that already, Major League Baseball already does a lot of stuff with Mother's Day, and there's a lot of initiatives to go along with Mother's Day and honoring our mothers and whatnot. We can couple that, and that's something that we have in the pipeline. We didn't do it this year just because we started the process in April, but that's something that I think is a great idea as well.
That's pretty cool. And we all know stories of women who got their mammogram because their child or, or close family member told them, you have to go in. We had a situation like that at our job where their child told them, you have to go in, and actually ended up diagnosing breast cancer very early. So it was exactly the scenario of proving the point that early detection saves lives.
I think the coalition building point is so important. So, I'm on the American Cancer Society board of Kansas City, and we, there's so many things specifically now that ACS is doing with their whole return to screening campaign. Mm-hmm. So this could be a great opportunity for organizations such as Society of Breast Imaging to partner up where we have common ground to work on initiatives for return to screening. So specifically, my breast center, we're working with ACS Kansas City to sort of have this, in terms of disseminating the message from a very collaborative approach. And then Matt, what you were talking about in terms of Mother's Day, we have now partnered with a nonprofit organization in Kansas City called Kicks for Boobs, where the founders specifically work on access for women of color. And there was an event recently over actually in May that was called Mamas, Mammos, and Mimosas. And it was amazing. There were so many mothers and their daughters, their aunts, their grandmothers. I was fortunate enough to speak at the event. Our breast center, our hospital partnered with them. But it's such a great outreach, you know, way to collaborate. And another time of the year where, yes, we aren't pumping out information October, but again, another critical time of the year where maybe we're seeing lower volumes, people not getting in for their mammogram, and just to do that outreach to get patients in the door. And from that event, you know, we were able to get some patients scheduled to come in who are overdue for their mammograms.
Were you actually serving mimosas?
There were mimosas served at this.
I've been thinking about doing an event like that. I was actually going to call mine Bosom Buddies. And
nice.
But I would love ideas from you guys about how to make it fun so that people will bring their bosom buddies with them. Like,
we had brunch, mimosas. It was just all the rage. A gift bag for those who attended, because everybody had to register, had some swag stuff, you know, from the breast center, lip balms, and, you know, things. But they loved it. And it was just such a cool way. And then, you know, of course, we got down to the nitty-gritty with knowledge, and then questions were asked. A lot of questions were asked, and it was just such an inspiring, wonderful event. And it wasn't in October, so that could be another avenue that, you know, others could take on.
And I think our last 10, 15 minute discussion here is the essence of what makes the summer series so great. You have breast experts from Missouri, New York, Pittsburgh, Philly, Houston, and we're all talking about different ideas to help get our patients back to getting their screening mammograms, get them back. You know, people had to go away for a little while for COVID, and we're not yet back. It was just a paper that was published last week or last month showing that, you know, we're still behind where we were before COVID. And I think we'd be remiss if, you know, it sounds like a basic question, but as breast imagers, as, you know, experts in this field, what in basic terms, why is it bad to skip multiple years of getting your mammogram? Skipping 1 year, but definitely multiple years. Why is that bad? I think we should at least touch on that for the next couple of minutes.
Okay, do you want to answer that question, Matt? So, I mean,
yeah,
I think, you know,
the
whole purpose of mammography, right, is
that's
to be able to
imaging
find
101,
cancers.
right?
Right. I mean, the whole purpose of mammography really is to be able to find cancers when they're small and easiest to treat. So, you know, I think, you know, it follows intuitively that, you know, if you wait longer, we're going to find things when they're just a little bit bigger and have the potential to be just a little bit harder to treat. Do any of you have regrets about the way that we handled the beginning of COVID? Wish we had done it differently. Wish we had never closed down. Wish the messaging was different. I mean, you know, it's easy to look back in like retrospect, but
I wish we never would have paused. I mean, especially now with the advanced cancers that we're seeing, we already have issues in this part of the country with screening adherence. As much as we're trying to do the outreach and we're trying to preach the gospel of routine screening mammography annually and why, this has really exacerbated our efforts in a negative way. So, you know, when I look back, I'm like, gosh, if only we didn't pause this. Now, you know, we have even more of an uphill climb when it comes to getting patients now in, and already patients are behind. And so that's the one thing that I feel that I wish we never would have paused.
Yeah, no, I mean, I feel the same way. It's hard to remember what it felt like, right? I mean, I'm in New York, and it's hard to remember what those like sirens going off, you know, 24 hours a day, and the empty streets and the no taxi cabs, and like just the whole sense of fear. It's hard to bring that back. I mean, I know that we were trying to do right by our patients, by our staff, and that we were trying to divert resources that we had in the hospital to what felt like were the most important things to do. I mean, we were converting, you know, cafeterias and conference spaces into patient, you know, rooms, but still, I wish we had.
No, I think this is, from my perspective, I think it's a bit of Monday morning quarterback, because you have to remember how little we knew we knew so little at the beginning. You remember when we were washing our groceries? I mean, we had so little information, and we are the patient-facing part of radiology. And for a lot of us, the patients that we care for are kind of the pillars of their families. So the thought of, putting a young mother, any parent, any human being at some risk that they could take home to their families, I think that was really difficult to do. You also have to keep in mind the schools were closed. So even our staff were personally affected about what they could potentially do. I do get your point, though, that perhaps we could have handled it differently. Could we have come up with a plan B from the beginning of a way to have those patients already put back into the system instead of just canceling their appointments? But I think it came on so acutely. And you have to remember the imagery we were getting out of China. I mean, it was really stark imagery about what could happen if this went uncontrolled. And so I think we just had to err on the side of caution. In retrospect, maybe having just a plan for how we would recover on the back end and how we could have kept contact with some of our patients. But now we know. So now we know for the future.
I agree. I mean,
make
hindsight's
sure we didn't
2020, right? I
die
mean,
at the time. Like screening mammograms didn't seem like anything. We all felt like we were gonna die, and it was pretty frightening. So I think, in hindsight, yes, things could have been done differently, but I don't really have any regrets about it because we didn't know. We had no clue. All you had to do was take the best guess and kind of move on, and you treat the situation as, a screening mammogram, missing it for the next, putting it off wasn't the most important thing at the time. It was ending up in an ICU in 3 weeks and potentially dying. So we did what we could, but
I think at that time we were thinking like it would just be a 1 or 2 month thing.
Right.
And we wouldn't think like at that time, no one think COVID was lasting for this long. And we probably could potentially do it slightly differently geographically, more like a case by case based approach. But as we discussed, there was so few we know, and we were like in the hope of just to get over it in a couple of months, but that didn't happen. And I also did some research about this, and then at least in my institution in Philadelphia, so we basically had barely any screening mammogram in April and May, but everything picked up in July. And then we did have a peak in July. We kept some diagnostic mammogram going in May and June. Then afterwards, we when people come back, we do see more BI-RADS 5 cases. I think that's probably just the point about you cannot skip mammogram for too long. If you skip, a couple of weeks or something, maybe not the end of the world, but if you skip for a couple of years, then we miss the window of catching early cancer.
Yeah, now studies are coming out saying that, looking back at it, now that we have a little bit more data, we were, during the time period of 2020, 2021, in comparison to 2019, our breast cancer diagnosis is lower. So, as a result of decreased screening, we're not finding them. And, we're starting to think that we are definitely going to be increasing our numbers of node positive breast cancers because we have missed screens. And it's unfortunate, but that's sort of the reality of missing your screen.
Yeah. So I think
that point.
Kind of to sum up, everyone, to go back to Toma's point, I think if I regret, if I think as a community as a whole, if we should regret something, I think it might be our response following the initial pause. Could have been better. And again, it's still being the Monday morning quarterback. I love that. I love these, but it's hindsight's 2020. It's, we didn't know initially. And then I was surprised when this paper came back because it feels like we're back to pre-COVID levels. I go into the breast center. I don't feel like I'm not doing as much as I was before COVID, but the proof is in the pudding. The data says nationally, we're not seeing as many screening mammograms as we were before. So that tells me right there that as a breast community as a whole, we're not doing as good of a job at making sure people understand that it is important to continue to come back, get your screening mammogram. We don't want to wait multiple years because we're going to find more invasive, more advanced cancers. So I think that that's a part where we can be kind of regret about.
So this is why I think what Nina described and what Amy described at their centers is so important, because what the data shows is that this is even more pronounced for women who are Asian, who are Hispanic, or who are Black. We have a greater proportion of those women who have not yet returned to screen. So when Amy described, partnering with an organization led by a Black female founder, that's incredible. When we partner with Black sororities, that's incredible, because even though it feels like you're just talking to one organization, each one of those people has a sphere of influence of their friends and relatives and all of that they're able to put the bug in their ear about returning to their screening. So I think it would be wonderful to really also keep in mind some of those populations as we work on the recovery.
Yeah, does anybody have
I
any
think it's
other
a great point.
ideas about targeting the groups specifically that have been hit the hardest? I think that's a really great idea with the sorority idea, and that targets a very specific group. So has anybody else done anything specifically to hit the it's like Asian, Hispanic, Black minority groups in order to bump those numbers up? Because I would like to apply that for us.
Yeah, some of what we've done is we have this education team that actually goes out into the community, and we'll partner with any organization, your gym, your church, your, wherever it is that you teach Taekwondo, they don't mind. So they'll partner with anyone. But what I really appreciated is that as part of this pandemic, they've gone out and built out specific education material to target some of these groups that need to have information pertaining to how their risk may be above average. And so I thought that was really powerful. And what we do is we empower anyone at the organization to be able to invite these educators to come out to speak to their communities. I think that's been really powerful. So I could raise a flag right now and say, hey, I'm here with my kid's teacher and she's interested. Can we have a session at the school, after hours one day? And it's great, done.
That's awesome. These are fantastic ideas. I think, if anybody out there is part of a group, to be able to, if you want to reach out, if you're in one of our markets, reach out to one of the people on this panel. We'd be happy to accommodate these things. I think these are fantastic.
Yeah, we've done these virtually. So throughout the pandemic, that was one thing we didn't stop. We just switched to doing them virtually. We would meet with these groups over Zoom. In some ways, I think that increased our reach, because before we had just been talking to groups in the community within driving distance. And virtually, we started partnering with companies that have an international reach even. So it's not really about our business. It's about disseminating information. Yeah. And so we've continued to do that. And the powerful thing is when you're in front of the community, you're in front of women, they're asking the right questions that teach you how to mold your organization and how to mold other educational material and how to reach other people. So it's been really impactful for us.
Another thing that's been happening specifically in Missouri and Kansas is related to, with COVID and all of this in terms of patients and access and not getting them in and all these things. We've formulated something called the Breast Health Equity Coalition, where we already have had issues specifically in Missouri and Kansas with breast cancer death rates, particularly in Black and Hispanic women. One of the largest hotspots actually in the United States for breast cancer deaths in Black and Hispanic women is the rural county in which I grew up in, Livingston County. So we already had all these issues, and then COVID has just compounded it. So this Breast Cancer Health Equity Coalition is comprised of stakeholders throughout sort of the Kansas City metro, anywhere from affiliated with breast centers to academic institutions to advocacy groups, from church representation. I mean, you name it, those who are involved, and specifically in outreach. And we are partnering with local health departments in certain counties where we know that the death rates are the highest. So we have the data, and we have essentially been partnering with these local health departments to have boots on the ground events, making sure there's mobile mammography there to screen patients, making sure if they can't afford it, that that we have that covered and providing education. So we're in its early stages. It's taken a lot of work to put together, but now we have the infrastructure in place, and we're really cautiously optimistic that we'll be able to make an impact.
That's awesome. That's absolutely awesome. I mean, I think, these are some fantastic ideas and great resources for our patients, and being able to help get us back to those pre-pandemic levels. I think we as a breast community need more of that, need more of these coalitions and outreach programs and whatnot. I think, the summer series is just one kind of small little facet of it. And I'm happy that we're continuing it, but there needs to be more outreach out there to let patients know we need to get our mammograms, and don't skip. We skipped that one couple of months during COVID, but now we need to come back. It's safe to come back. It's important to come back. You're going to save your life by coming back. So the last 10 minutes, we kind of hit pretty much everything that I wanted to hit today. Does anybody want to kind of raise any other topics that they'd like to discuss, or do we want to go kind of around and kind of give final things about what they want to get across today about COVID in relation to breast imaging?
I guess I'll share / ask a question.
Sure.
Initially when the COVID vaccine came out and we were seeing that patients would have axillary lymphadenopathy, they would have these swollen lymph nodes in their armpits, for any patients who might be watching. After receiving the vaccine, we'd initially told patients, if you've gotten your vaccine recently, wait a few months before coming to get your mammogram. But I just want to emphasize that for us, and I think for a lot of breast radiologists around the country, as we now have more data, we have so much more comfort with this. Don't let the vaccine delay your coming in. And I'm happy to hear from you guys. What are you doing with patients and their vaccines or their boosters in terms of their breast imaging timing?
I mean, I think that the recommendations now, of course, like they've evolved over time, right? Like you're saying, and we didn't know anything before, and we were saying, try to get your mammogram first, or then you get your vaccine, then delay it for 4 weeks or so. And then we saw this adenopathy and thought, okay, why is this lasting so long? And biopsied a lot of it, and it always came back reactive. And now we're realizing too, and the SBI of course has come out with statements regarding what to do for these specific cases, and that it is fairly common, and I think more common than, I can't remember what the exact initial data said for the trials or the studies for the vaccine, but and the length that the adenopathy is lasting is quite long. I mean, they're saying now up to 40 some weeks it can potentially last. Like, it's a very long time.
How have all of you changed what your recommendations are in terms of follow-up once you see what you believe to be reactive adenopathy?
I mean, I think that if they have a reason to have reactive adenopathy, let's say if they did have the vaccine in that arm and then they have it and it's nothing crazy, it doesn't look like a lymphoma or something massive, I think you should drop it. And you can, but then, if you're a little bit more cautious and you do want to follow it in, let's say 6 weeks or now I think it's 12 weeks we're supposed to recommend, and it stays the same at that point in time, I'd be done with it.
I think it really comes down to a breast imager's comfort level. And remember that not everybody in this country are strictly breast imagers. I mean, there are general radiologists that are reading some breast and may not read as much breast as maybe we do. And so they may not feel as comfortable just kind of letting it go. So I do think there is still a lot of variability out there. We'll typically, I personally will typically maybe do a short interval follow-up. And if it all looks the same or even slightly small, you don't see any cortical, like focal cortical thickness or bulge or something like that, I just let it go. But I can see how some might, err on the side of caution with that. And yeah, I mean, we're seeing the same things as many others in terms of seeing that reactive lymphadenopathy for months on end. I think another important thing, though, for us to impart upon our patients is, and I'm not sure if you all are seeing this, but just a lot of misconceptions. Like, a patient will come in with a lump in her breast and she's like, well, I just thought it was related to my COVID COVID vaccine. And I was like, no, honey, that's the axilla, that's the armpit. So I think that there's a lot of unfortunate misconceptions, which I see it all too often in the breast center where patients are feeling something and it ends up being a cancer, like, oh, it's just related to my vaccine. It's like, nah, it doesn't, it doesn't travel to, this is lymphadenopathy. Lymph node swelling is different from a cancer. So I think clearing up those misconceptions is important as well for us to do with our patients.
And even to the lymph nodes, when we tell them we think that they're big and it's okay, it's because of the vaccine, then they tell me, it's almost like this horrified feeling from them being like, well, why did the vaccine do this to me? Like, this is a bad thing that my lymph nodes are big. And then they're scared that it's negatively impacting their health somehow. Like, that means they have cancer or something because their lymph nodes have gotten big. I don't know if anyone else has seen that, but I've had a handful of patients very concerned that their lymph nodes are big because they don't, I try to educate and tell them that's okay. It's your body responding.
It's a good thing.
But they think it's really a bad thing.
I think patients are getting more of that education now. So thank you for doing that. I will say I really appreciated the study that led by Hannah Chung, looking at separating COVID-related lymphadenopathy versus malignant lymphadenopathy to try to help radiologists differentiate that. So any radiologists who are interested in that was very interesting. But it basically came down to, for the COVID-related, it typically was a cortical thickness less than 5.4 millimeters was what they had it as in that study. And you would typically see greater than 3 lymph nodes being involved versus less than 3 in malignant lymphadenopathy. And of course, the morphology, right? So if you've completely lost the fatty hilum, then be worried. But I just thought it was an interesting paper, and it does show that trust your radiologists. You can go in. They are very capable of trying to separate out, what's malignant versus not.
Yeah, and to go back to Amy's point about people just kind of blowing off thinking, it's the COVID vaccine. Mm-hmm. If you're experiencing an issue, even after your COVID vaccine, I mean, it's better for us to tell you that it's nothing than for you to kind of rest on your laurels and just be like, oh, no, I had the vaccine. I remember seeing this thing on the news where the vaccine can cause an abnormal screening mammogram. I'm good. Come in, get it checked out, have us tell you that it's nothing, have us tell you that's related to the vaccine, or have us tell you that, okay, there needs to be something else that needs to be done, or, okay, this is nothing, it's a cyst, or it's whatever. It's better for us to tell you that than for you to kind of just assume that it's related to something and like the COVID
Another
vaccine.
Well-meaning, I think, problem misstep, in the way that COVID was handled by all of us, again, with the best of intentions, but creating this association between mammography and breast cancer and the COVID vaccine, in retrospect, probably not that helpful. I think we've learned like a lot of really hard lessons during this whole process of, it's hard when you're dealing with something for the very first time,
Yeah, absolutely. I mean, hindsight's 2020, man.
I also feel like, to be partnered with the primary care physicians and the OBGYN groups are very important, because I feel like patients still go see their primary care doctors, see their OBGYNs, and how the message come across from them regarding how to come in for your mammogram, don't delay those. So I find it's very important to have a very good partnership with those primary care physicians.
Are you guys finding that your primary care physicians are changing at all what their screening recommendations are, sort of over the course of the past couple of years, when I think people have become, or at least I hope people have become, a little bit more aware of health equity and disparities? I think people in our health system, we had lots of referrers who really held really tight to the U.S. Preventive Services Task Force guidelines. And I feel like they're loosening their grip on those things a little bit. I don't know whether other people feel that, but I don't feel like I'm having that argument as much now as maybe I was having 2 or 3 years ago. So anybody else?
I'll tell you, I was in on a discussion recently with a group of family medicine docs and OB-GYNs. And we had a few, I think I might've been the only radiologist there. But they were discussing that, and it was the obstetricians that kind of backed us up. And we experienced just that. It was kind of the family medicine people were like, well, okay. Yeah, they kind of backed down a little bit. And, you know, it was kind of a small portion of why we were talking. It was a greater discussion about other things, but the USPSTF was brought up, and it was the obstetricians arguing with the family medicine docs. And it was interesting. It was interesting.
I feel like because OB/GYN, they also recommend breast exams, you know, to a certain degree. So, you know, I do think they also disagree with those general recommendations. I do feel like breast exams is helpful, because especially for patients who have very dense breast, you barely can see anything on mammogram, and then, you know, I think I have patients who actually had negative mammogram, and then the physician felt something, and it was like so vague, you know, when we do further workup.
Absolutely. Well, unless other people have things that they want to add, we are at our hour time limit, or time slot, or whatever you want to call it. But this has been a fantastic discussion. Thank you for helping us kick off this year 3 of the SBI Summer Series. Next week, we will have another discussion about the breast radiologist role in social media, given and moderated by TikTok star Robin Roth from Cooper University in New Jersey. So that will be an exciting discussion, a little bit different. So thank you all. If anybody has anything else to discuss, please reach out to us on social media. We are very open about our passion for breast imaging and breast health. So look forward to having some more discussions.
Thanks, Matt. Thanks for putting up with me and my technical challenges.
Thanks for hanging in there, Nina.
Thank you, guys.
Thanks, everyone.